Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. So in this session, I'll be doing the quick revision of the topics related to the respiratory system. So the first topic I'll be doing the quick revision is on the pulmonary function test. What is the purpose of doing the pulmonary function test? That is mainly to differentiate the obstructive lung diseases from the restrictive lung diseases. Now what are the examples of the obstructive lung diseases? That includes like asthma, then we have bronchitis. The next important clinical condition is the bronchiectasis, right? And the next condition is the cystic fibrosis and COPD. So these are the conditions which will be causing, which are the obstructive lung diseases. Whereas the restrictive lung diseases, the examples that include number one, sarcoidosis, right? Then pneumoconiosis. Then we have interstitial lung disease. Then drugs causing the pulmonary fibrosis. Example include the amiodarone. And so these are the examples for the restrictive lung diseases. And apart from this, we have some extrapulmonary causes for restrictive lung diseases. Now, what are those extrapulmonary causes? The extrapulmonary causes include the diaphragmatic palsy, cervical spine injury causing phrenic nerve injury, amyotrophic lateral sclerosis, myasthenia gravis, Guillain-Barré syndrome, kyphoscoliosis, ankylosing spondylitis, obesity. These are all the conditions where you will have, which are extrapulmonary causes for the restrictive lung diseases, right? Now, how is that you will be able to differentiate the obstructive lung diseases from the restrictive lung diseases? Okay. Now, first and foremost, the very important point of difference is the FEV1 by FVC. So this is a very important parameter which will help us to differentiate the obstructive lung diseases from the restrictive lung diseases. So you take the OLD, that is the obstructive lung disease. The FEV1 by FVC will be less than 70%. Whereas you take in case of the restrictive lung diseases, the FEV1 by FVC will be more than or equal to 70%. And in both of them, you take FEV1 and as well as FVC. In both of these clinical conditions, like OLD and RLD, the FEV1 and FVC both are decreased. And you have another important terminology called forced mid-expiratory flow rate. So this we call it as, right, that is 25 to 75%. So if you take the forced mid-expiratory flow rate, that is reduced, so it is less than, right, 50% of the predicted value, right, less than 50% of the predicted value. Whereas in case of restrictive lung diseases, it is also being decreased, right? And this is like mainly useful for assessment of the obstructive lung diseases rather than the restrictive lung diseases. Then you take the total lung capacity. Total lung capacity in case of the obstructive lung diseases, either normal it is or it is elevated. Whereas in restrictive lung diseases, the total lung capacity will be reduced. And another very important is the residual volume. Residual volume in obstructive lung diseases, it is increased. And in restrictive lung diseases, it usually decreases, right? Or it can be normal also. So residual volume being normal, it is mainly present in case of the extrapulmonary causes for the restrictive lung diseases, right? Then next important parameter is the DLCO, that is diffusion capacity of the lung for carbon monoxide. So if you take the DLCO in case of the obstructive pattern, right, DLCO, it is usually normal, okay, but only in case of the emphysema, only in case of the emphysema, the DLCO is being decreased. Whereas you take in case of restrictive lung diseases, the DLCO is being decreased. Whereas it can be normal in case of the extrapulmonary causes for restrictive lung diseases. And you need to know that the pulmonary function tests are measured with the help of the spirometry. But there are certain volumes and capacities which cannot be measured by the spirometer or the spirometry. So the volumes that cannot be measured is number one, the residual volume. next important is the functional residual capacity, and the next important is the total lung capacity. So these are the volumes and capacities that cannot be measured by the spirometer. So then what is the method by which you can measure this residual volume, functional residual capacity, and as well as total lung capacity is, that is by body plethysmography, right? Then helium dilution method, then nitrogen washout method. But out of all these, the best method for assessment of residual volume, functional residual capacity, and total lung capacity is the body plethysmography. So this is in nutshell about the pulmonary function tests. So the next important topic in the quick revision is the chronic obstructive pulmonary disease. So chronic obstructive pulmonary disease, it's an obstructive lung disease, and it is a progressive disorder, right? And it is irreversible. Now what is the difference between COPD and bronchial asthma is, bronchial asthma, it is a disorder where you will have reversible bronchial obstruction, whereas COPD, it is an irreversible bronchial obstruction, and it is the disease of the smaller airways, right? So it is the disease or the disorder of the smaller airways. And what are these particular smaller airways? Smaller airways are those which are present distal to the terminal bronchiole. And the smaller airways definition is that the internal diameter, it is less than 2 mm, right? And if you take this smaller airways, you have the absence of the cartilage. So they are non-cartilaginous airways, and they are present distal to the 8th generation of the airways, or like down to the terminal bronchioles, you have the presence of the smaller airways, right? And you need to know that there are two important subtypes in case of the COPD. What are the two important subtypes in patients with COPD is, one is the chronic bronchitis, right? And another important subtype is the emphysema. So these are the two important subtypes in case of the chronic COPD. But between these two, which is more common, the chronic bronchitis is like more common than compared to that of the emphysema. And at the same time, you need to be aware of what is the important risk factor for the development of COPD, that is the smoking, right? And how is that we calculate that with the help of pack years. And we also have one important risk factor, that is alpha-1 antitrypsin deficiency will also result in the development of the emphysema. This alpha-1 antitrypsin deficiency is mainly due to mutation of a gene called SERPINA1 gene. That is what is responsible for, or SERPINA1 gene mutation is responsible for the alpha-1 antitrypsin deficiency, right? And the next important thing is occupation, where there is exposure to fumes and chemicals, and environmental pollution. So these are all the risk factors for the development of the COPD. And you take this alpha-1 antitrypsin deficiency, what type of emphysema this will lead to? This particular alpha-1 antitrypsin deficiency will result in the pan-acinar type of emphysema. Now what do you understand by this word pan-acinar type of the emphysema? Pan-acinar emphysema is the entire acinus, which is the gaseous exchange unit, it is abnormally and irreversibly dilated. Now what is that particular acinus? What are the components within the acinus? The components within the acinus is, number 1, the respiratory bronchioles, number 2, the alveolar ducts, number 3, the alveolar sac, number 4, the alveoli. These are the 4 important components of the acinus. So the entire acinus, it is abnormally and irreversibly dilated. That is what is your pan-acinar emphysema. And this alpha-1 antitrypsin deficiency is also present in the other clinical conditions, also observed in cases of the bronchiectasis, also observed in cases of the hepatic cirrhosis, also observed in cases of vasculitis and pancreatitis. So in all these conditions, you have the presence of the alpha-1 antitrypsin deficiency, right? Now let me take up the differences between the chronic bronchitis and as well as the emphysema. So chronic bronchitis is that these patients, they have cough with mucoid expectoration. So this cough with mucoid expectoration, that will be present for 3 months and 2 consecutive years in case of chronic bronchitis. Whereas in patients with emphysema, the clinical features that will be present is the dyspnea, and that too what it is exertional dyspnea, right? And how is that you will be able to assess the severity of the dyspnea? That is by MRCP grading. That is, MRCP grading is the one which will help us to grade this particular dyspnea. What is MRCP? Or yeah, so rather than this MRCP, we call this as Modified Medical Research Council Scale for dyspnea. Okay, right? MRCS, Modified Medical Research Council Scale for dyspnea. So that is how you will be able to assess the severity of the dyspnea, in which again you have 1, 2, 3, 4 grading. And next important is in chronic bronchitis, they have the presence of the cyanosis. That is the reason why these patients, they are called as the blue bloaters. Whereas patients with emphysema, cyanosis is absent. So that is the reason why these patients, they are considered as the pink puffers in cases of the emphysema. That is a very important differentiating point, that is cyanosis present in chronic bronchitis, absent in case of the emphysema. And the age group at which you see this chronic bronchitis is around 40 to 45 years, right? Whereas emphysema, it is present more than 50 years, right? And the infections, they are very common, right? The infections, they are very common in case of the chronic bronchitis, but whereas you take the infections, it is occasional in patients with the emphysema, right? And next important is the respiratory failure or respiratory insufficiency. Because the infections are very common, so you have repeated respiratory insufficiency in chronic bronchitis, whereas in emphysema, the respiratory insufficiency, it is present only in the terminal stages. Right, only in the terminal stages you have the presence of the respiratory insufficiency in case of the emphysema. And next important is the presence of the cor pulmonale. So if you observe this cor pulmonale is present very commonly in case of the chronic bronchitis, right? Whereas you take in case of emphysema, the presence of the cor pulmonale, it is rare, right? And next is the presence of the airway resistance. So if you take the airway resistance, it is present in case of the chronic bronchitis, whereas the airway resistance, it is normal in patients with the emphysema. Then followed by that, the elastic recoil. So elastic recoil, right? Elastic recoil, it is absent in case of the elastic recoil, it will be normal in case of the chronic bronchitis, whereas in patients with emphysema, the elastic recoil, it is low, right? Elastic recoil will be low, right? And if you take the chest radiograph, okay, so chest x-ray in patients with chronic bronchitis is that where you have the presence of increased bronchovascular markings, whereas you take in patients with emphysema, you have the presence of bilateral hyperlucent lung fields, right? Bilateral hyperlucent lung fields. And second important is the presence of the tubular heart, right? The second important is the presence of the tubular heart. And next is the presence of low set diaphragm. So this will be the X-ray picture in patients with the emphysema. And appearance wise, already we have discussed blue bloaters in case of chronic bronchitis and as well as pink puffers in patients with the emphysema, right? And you need to know the complications that we come across in patients with the COPD. So complications is, one important is polycythemia. So why is that there is polycythemia? Because these patients, they will have hypoxia, which is a stimulus for erythropoietin production, and the erythropoietin, when it is produced in excess quantity, that will increase the RBC production, and that we call it as the secondary polycythemia, right? And another important complication is there will be development of pulmonary hypertension and as well as the cor pulmonale. So what do you understand by this word cor pulmonale is that where there is presence of or where there is development of right ventricular dilatation followed by that right ventricular failure secondary to increase in pulmonary artery pressures. So that is what is called as the cor pulmonale. Then what are the other complications that you come across in these patients? The other complications is they will go into a state of the respiratory failure, right? They go into a state of respiratory failure. You take in patients with the chronic bronchitis, it is type 2 respiratory failure, whereas you take in patients with emphysema, it is the type 1 respiratory failure. So you take type 2 respiratory failure. Type 2 respiratory failure is that where there is presence of or where there is hypoxia and hypercapnia, that will be type 2 respiratory failure. Whereas in emphysema, it is type 1 respiratory failure where you have only hypoxia, whereas the carbon dioxide levels, either it may be normal or decreased in case of the type 1 respiratory failure. So these are some of the important complications that you come across in patients with the COPD, right? Next important thing is the workup. So So how is that you will be able to diagnose the COPD is mainly by your pulmonary function test, where your FEV1 by FVC will be reduced, and how much that will be? That will be less than 70%. And the other way by which you will be able to differentiate these two is chest X-ray. Chest X-ray in chronic bronchitis, you will have increased bronchovascular markings, whereas in emphysema already I have discussed it is bilateral hyperlucent lung fields, tubular heart, and as well as the low set diaphragm. And already we have discussed the respiratory failure. In chronic bronchitis it is type 2, and in case of emphysema it is type 1 respiratory failure, and that you will be able to make out by the arterial blood gas analysis. And next important is you need to assess the alpha-1 antitrypsin levels. The alpha-1 antitrypsin levels has to be done if a young patient who has developed COPD, you need to suspect alpha-1 antitrypsin deficiency, and if there is family history of COPD, then you need to suspect the alpha-1 antitrypsin deficiency. So in these two patients, you need to check the alpha-1 antitrypsin levels, right? Then how is that you will be able to assess the severity of the COPD, and how will you assess that, how will you treat the patients with the COPD? So that is by the GOLD criteria, right? So that is by the GOLD criteria. So if you take the GOLD criteria, so GOLD criteria, what exactly it means? It is global initiative for obstructive lung disease, right? Global initiative for obstructive lung disease, that is what is called as the GOLD criteria. So according to this particular GOLD criteria, so what is the parameter which will assess the severity in case of the GOLD criteria is the very important parameter, that is FEV1. So in this you have 1, 2, 3 and as well as 4. So you take 1, that is mild, okay, whereas 2 it is moderate, then 3 it is the severe, then 4 it is very severe, okay. So this is how. And what will be the FEV1 value? So the FEV1 value in case of mild, it will be more than or equal to 80% of the predicted value, right? Whereas in 2 it is 50 to 79% of the predicted value, whereas in severe it is 30 to 49% of the predicted value, whereas in very severe it is less than 30% of the predicted value. Then how is that you will do the treatment for COPD? The treatment for COPD is that, so in case of 1, we give short-acting beta agonist, that is salbutamol and as well as the terbutaline, or the very important is you need to give the anticholinergic drugs. These anticholinergic drugs include ipratropium bromide and thiotropium bromide. Then you take in case of moderate, what is that we need to add? To this, we need to add the LABA, that is long-acting beta-2 agonist, right? Long-acting beta-2 agonist, that includes salmeterol or formoterol. Whereas in case of the severe form of COPD, that is the point when you need to add the inhaled corticosteroid, right? That is the point when you need to add the inhaled corticosteroid. Whereas in case of very severe, where there is presence of the hypoxemia, you need to add long-term oxygen therapy, right? You need to add long-term oxygen therapy, okay? So this is about the treatment of COPD, and this is a quick recap of the COPD. So now let me just do a quick revision of the bronchial asthma. So bronchial asthma, this is also the disorder of the smaller airways. But what exactly is the difference between the bronchial asthma and COPD is the reversibility. So in case of bronchial asthma, it is a reversible airway disease, right? So this is a reversible airway disease. So this bronchial asthma, which is characterized by like episodic reversible bronchial obstruction, and that is due to hyper-responsiveness of the tracheobronchial tree. And this hyper-responsiveness, right? So this hyper-responsiveness of the tracheobronchial tree, it is to multiple extrinsic and as well as the intrinsic stimuli, right? So this hyper-responsiveness is to multiple extrinsic and intrinsic stimuli. And what will be the characteristic features in case of the bronchial asthma is the presence of the wheeze. And this wheeze, it is mainly during the expiratory. But as the severity of the bronchial asthma increases, this particular wheeze, which is expiratory, slowly it becomes like the wheeze is being heard even during the inspiration. And at one point of time, right, in patients with the bronchial asthma, there is no wheeze at all, right, where the chest will be completely silent. So the chest is like completely silent means it's a very severe form of asthma where the bronchoconstriction is very severe, where the air is not moving in and the air is not moving out. That is like very severe form of asthma where there is no passage of air, because of which the wheeze is like completely absent. And if you take this bronchial asthma, we have the extrinsic asthma, right, and the other one is the intrinsic asthma. What exactly is the difference between the extrinsic and as well as the intrinsic asthma? So extrinsic asthma, this is also called as atopic asthma. This is also called as the early onset asthma. Whereas intrinsic asthma, it is also called as non-atopic asthma, right? Or it is also called as the late onset asthma. Now what is the difference here? So the early onset asthma, that means the early age of onset. Atopic asthma, that means external allergen, it has a strong role, right? Extrinsic asthma, that means it is the external agent which is inducing the development of asthma, right? And this early onset asthma or extrinsic asthma or atopic asthma, it is observed in the children. Whereas intrinsic asthma, which is also called late onset asthma, it is observed in adults, right? It is observed in adults. So you take the intrinsic asthma, it is usually observed in the infection and it is non-atopic. That means the external allergen, it has no role in the development of the asthma. And in case of the extrinsic asthma, you have a positive family history, right? A positive family history. Whereas in case of the intrinsic asthma, there is no family history. And the extrinsic asthma, you have external allergen as an important role. So in response to that, there will be increase in the eosinophil count in the extrinsic asthma. Whereas in intrinsic asthma or late onset asthma or non-atopic asthma, the eosinophil levels will be normal because there is no role of external allergen. And the immunoglobulin levels, that is IgE levels, they are elevated in case of the extrinsic asthma, whereas the IgE levels, they are normal in case of the intrinsic asthma or non-atopic or late onset asthma. So these are some of the differences between the extrinsic and as well as the intrinsic asthma. And as such, if you take asthma, like mainly you take the extrinsic asthma, which is allergen associated. So it is a type 1 hypersensitivity reaction, right? It is a type 1 hypersensitivity reaction, and there are many precipitating factors for the development of the asthma. The precipitating factors include the allergens such as food, pollen, mold, then smoking, then extreme temperatures, that is extreme cold temperatures, infections like hay fever, bacterial and viral infection, medications, that is NSAIDs and as well as the non-selective beta blockers, the acid reflux, that is GERD, and then exercise or emotional stress and as well as the anxiety. So these are all the precipitating factors. These precipitating factors, they will induce the cells, right? These precipitating factors, they stimulate the cells which have an important role in the development of asthma, and these particular cells, they will release the mediators. Now what are these cells? These cells include mainly the eosinophils, right? Then you have the mast cells which will be releasing the histamine, then macrophages, then lymphocytes. So these cells, they will release the inflammatory mediators, right? And what are these inflammatory mediators? That includes the histamine, prostaglandins, thromboxanes, adenosine, substance P, leukotrienes. So these are the inflammatory mediators. So if you take these inflammatory mediators, they cause the bronchoconstriction, right? And this particular bronchoconstriction is the one which will be responsible for the development of the wheeze, right? This bronchoconstriction is the one which is responsible for the development of wheeze. So these patients, so what will be the classical clinical feature? Dyspnea, followed by that cough, right? So cough in these patients with bronchial asthma, it is associated with the development of the sputum production. So in the sputum of these patients with the bronchial asthma, you have the Kezirman spirals, you have the Crayola bodies, you have the charcoal-laden crystals. Kezirman spirals are what? These are spiral-shaped mucus plugs, right? Spiral-shaped mucus plugs. Whereas you take the Crayola bodies, these are the ciliated columnar cells which are sloughed from the bronchial mucosa. And next is the charcoal-laden crystals. The charcoal-laden crystals, these are like slender and pointed, right? These charcoal laden crystals, these are slender and pointed, and the presence of these charcoal laden crystals, it is suggestive of the eosinophilic inflammation, right? So, and these charcoal laden crystals are also present in certain parasitic infections like Entamoeba histolytica. So this is about like the sputum in patients with the bronchial asthma. And you need to know the variants of the asthma. The variants of asthma is that we have what is called nocturnal asthma. Nocturnal asthma is that there is overnight fall in the FEV1. And how much is that overnight fall in FEV1? That is more than 20% in case of nocturnal asthma. Then we have gastric asthma. Gastric asthma is like the associated with the GERD. So immediately after taking food, because of the reflux, there will be development of the dyspnea, and that is what is called the gastric variant of asthma. And the treatment that what we give in case of the gastric asthma is the proton pump inhibitors. And the next one is the exercise induced asthma. So exercise induced asthma, it begins during the exercise or within 3 minutes of starting the exercise, and it will reach the peak. The bronchial asthma, it will reach the peak within 10 to 15 minutes, right? And this particular asthma, it resolves by 60 minutes. Right, the bronchial asthma, it resolves by 60 minutes. That is what is your exercise induced asthma. And how is that you can prevent the development of exercise induced asthma is, before the starting of the exercise, you need to give bronchodilators, that is short acting beta 2 agonist, and then you need to start and you need to go ahead with the exercise. Then next is the cardiac asthma, which is associated with the left ventricular failure causing pulmonary edema where there can be wheeze. So here the treatment is you need to give diuretics in case of the cardiac asthma. Then we have drug induced asthma. Drug induced asthma, it includes the NSAIDs. Examples of these NSAIDs are the aspirin, then diclofenac, and then the ketorolac. These are the drugs which can cause bronchoconstriction by increasing the levels of the leukotrienes, and they will induce the development of the asthma. And the severe form of asthma is the status asthmaticus. Status asthmaticus is a medical emergency. These patients, they will have hypoxia, and these patients, they will develop cyanosis, and they will not be able to speak, right? They will have what is called monosyllables. Why is that they have monosyllables? They are not able to speak continuously because of the dyspnea. And the heart rate, it will be like more than 120 per minute, right? Whereas the respiratory rate, it will be like more than 30 per minute. And these patients, they have a characteristic pulse which is called as the pulsus paradoxus, right, where systolic blood pressure will fall by more than 10 millimeters of mercury during inspiration is what is called as the pulsus paradoxus, right? And what exactly is the drug of choice in case of status asthmaticus is, you need to give SABA, that is salbutamol nebulization has to be given. Along with salbutamol nebulization, you also need to give the steroids, that is intravenous hydrocortisone should be given in case of the status asthmaticus. Then how is that you will be able to diagnose the asthma? You should be able to demonstrate the reversibility. So for which you need to do what is called as bronchodilator response test, right, for which you need to do a bronchodilator response test. So if you take this bronchodilator response test, what is that you need to do is you need to check the baseline FEV1, right? After estimating the baseline FEV1, you need to give the short acting beta 2 agonist, and again you need to check the FEV1, right? Now if the value of FEV1, right, if it is increasing more than 12%, that tells that there is presence of the reversibility. That tells there is presence of reversibility. So it is based on your reversibility testing by your bronchodilator response test, you will be able to diagnose the asthma. Then how is that you will be able to assess the severity of the asthma? That is based on the FEV1 value, right? So that is like we classify that into mild, moderate, then severe, and next is the very severe. Okay, so you take mild, the FEV1 value will be more than 70%, whereas in moderate, the FEV1 value will be around 40 to 69%, and very severe, the FEV1 value is less than 40%, and in very severe, it is less than 25%, right? Then how is that you will treat these patients with the bronchial asthma? First and foremost, you should avoid the allergen, you should avoid the risk factor, right? And you need to do desensitization therapy or immunotherapy for the allergen. And next important is the drugs, right? Next important is drugs. Now what is this particular drugs that you will be giving is, that all completely depends upon the severity of the asthma. You take in case of mild, the intermittent form of asthma. mild intermittent form of asthma, you need to give the short acting beta agonist should be given, but this short acting beta agonists are given on SOS basis whenever there is dyspnea, whereas you take in case of mild persistent form of asthma, you need to give the short acting beta agonist, right? And along with the short acting beta agonist, you need to give low dose inhaled corticosteroids, right? Low dose inhaled corticosteroids, whereas you take in case of the moderate persistent form of asthma, we give inhaled high dose corticosteroids, right? High dose inhaled corticosteroids. Along with that, you need to give short acting beta agonist, and you also need to give phosphodiesterase inhibitors, that is the theophylline should be added. Whereas in case of the severe persistent form of asthma, here we give the oral steroids, right? Here we give the oral steroids. Along with that, theophylline, and along with that, the short acting beta 2 agonist is what we give in case of severe persistent form of asthma. And in very severe form of asthma, like you need to give the drug of choice as the short acting beta agonist, and intravenous hydrocortisone should be given, and along with that, the oxygen therapy should be supplemented in case of very severe form of asthma, right? So what exactly is the drug of choice for acute asthma exacerbation now? Salbutamol nebulization. Now, what is the drug of choice for recurrent attacks? You need to give inhaled corticosteroids. And what is the drug that we give in case of the chronic persistent form of asthma, right? Refractory asthma. We give anti-IgE. Example is the omalizumab is the drug what we give in case of the chronic persistent asthma, right? And what are the drugs that we give for the prophylaxis in case of the asthma? So we give the leukotriene inhibitors. Examples of the leukotriene inhibitors are montelukast and as well as the Xileuton. So these are leukotriene inhibitors. And the other examples are the mast cell stabilizers. Examples of the mast cell stabilizers are sodium chromoglycate and as well as nidochromyl sodium. That is about the mast cell stabilizers. So, and how is that you will be able to assess the control of asthma? The daytime symptoms should be reduced to less than 2 times per week, and usage of short acting beta 2 agonist should be less than 2 times per week. There should not be any nighttime symptoms. There is no limitation of, there should not be any limitation of the activity, and the FEV1, it should revert back to normal, right? Or your peak expiratory flow rate, that should be reverting back to normal. So these are the indices which will tell you that there is control of asthma, right? Daytime symptoms like less than twice per week, usage of the short acting beta 2 agonist less than twice per week, no nighttime symptoms, no limitation of activity, normal peak expiratory flow rate and normal FEV1 values. These are the indices which will determine the control of asthma, and this is about the quick revision of the asthma. So the next important topic for the quick revision is the respiratory failure. So if you take this topic of the respiratory failure, we have totally 4 important types of the respiratory failure. That includes type 1, type 2, type 3 and as well as the type 4 respiratory failure. So in case of the respiratory failure, the lung function is inadequate to meet the metabolic demands of the individual, and it is the lung is unable to maintain the normal arterial gas levels in the blood. And you take type 1 respiratory failure, it is acute hypoxemic respiratory failure. Okay, so this acute hypoxemic respiratory failure, why does it occur? This is due to alveolar flooding, right? And this alveolar flooding, this is due to pulmonary edema, or it could be due to pneumonia, or it could be due to the alveolar hemorrhage. And in these patients with type 1 respiratory failure, there will be hypoxia. And what will happen to the carbon dioxide levels? The carbon dioxide levels, they remain normal or they are decreased because of increase in the respiratory rate. And next important is the AA gradient for the oxygen. So AA stands for the arteriolar alveolar gradient, right? Or alveolar arteriolar gradient for the oxygen, it is increased in case of the type 1 respiratory failure. Now, what are all the various etiologies for the type 1 respiratory failure, right? That includes the mild to moderate form of the bronchial asthma, Then next important condition is the acute respiratory distress syndrome. Then you take patients with the congestive heart failure and as well as the pneumonia. Okay, these are all the etiologies for type 1 respiratory failure. And how is that you treat? You need to treat the underlying cause. And if there is severe form of hypoxemia, these patients, they have to be placed on mechanical ventilator with the help of the endotracheal tube, right? So this is your type 1 respiratory failure. Then you take type 2 respiratory failure. So type 2 respiratory failure, this results from the alveolar hypoventilation, right? This results from the alveolar hypoventilation. Okay, so this type 2 respiratory failure, which is resulting from the alveolar hypoventilation, this results in inability to eliminate the carbon dioxide effectively, right? This results in inability to eliminate the carbon dioxide effectively. So these patients, they will have hypoxia and as well as the hypercapnia. That is what you will observe in case of type 2 respiratory failure. Now, what are the etiologies that will be causing type 2 respiratory failure? Is impaired central nervous system drive to breathe, right? Impaired CNS drive to breathe. Now, what are the causes or what are the scenarios where there is impaired CNS drive to breathe? That is due to drug overdose, right? What are these particular drugs? That includes the opioid overdose, right? And then the brainstem injury. Then you take in patients with the hypothyroidism, right? And the second important condition which will be causing the alveolar hypoventilation is impairment of the neuromuscular transmission, right? Impairment of the neuromuscular transmission. Now, what are the conditions where there is impairment of the neuromuscular transmission? Is in patients with the myasthenia gravis, in patients with the Guillain-Barré syndrome, in patients with the amyotrophic lateral sclerosis, right? And the other conditions are cervical spine injury and then Duchenne's muscular dystrophy, right? And the other conditions are the conditions where there is directly respiratory muscle weakness itself. And you observe that in patients with the myopathy and as well as the electrolyte derangement. These are all the etiologies that will be causing your type 2 respiratory failure. And what is the treatment for the type 2 respiratory failure? Same, you need to treat the underlying cause and you need to connect the patient to the mechanical ventilator with the help of the endotracheal tube, and that helps in the respiration. Okay, that is your type 2 respiratory failure. Whereas the type 3 respiratory failure is that which results of the lung atelectasis. Right, so this results of the lung atelectasis. This is also called as perioperative respiratory failure. Right, so this is also called as the perioperative respiratory failure. So in these patients with type 3 respiratory failure, after the surgery, the individual is unable to recover back the respiratory muscle strength, right? And that will result in lung atelectasis and respiratory failure. And how is that you treat this type 3 respiratory failure? Is you need to do a chest physiotherapy, right? So chest physiotherapy is the one which will increase the muscle strength, and if required, the patient has to be connected to the mechanical ventilator. Then you take type 4 respiratory failure. Type 4 respiratory failure, this is due to a cardiogenic shock. Right, so this is due to the cardiogenic shock. So whenever there is cardiogenic shock, like what will happen is the cardiac output will be reduced and respiratory muscles require the 5% of the cardiac output. So once the cardiac output is reduced, the respiratory muscles will receive less than 5% of the cardiac output, and that will result in the respiratory muscle paralysis. Right, that will result in respiratory muscle paralysis. So basically type 4 respiratory failure is due to what? Type 4 respiratory failure, this is due to hypoperfusion of the respiratory muscles, right? This results from hypoperfusion of the respiratory muscles. Then how is that you need to treat? You need to treat the patient by connecting the patient to the mechanical ventilator. That will improve the cardiac output of the individual, and thereby respiratory muscle perfusion will be increased. So these are the types of respiratory failure: type 1, type 2, type 3, and as well as type 4. So type 1 you will have hypoxia and carbon dioxide levels will be normal or reduced. And type 2, you have hypoxia and hypercapnia. And type 3 is due to lung atelectasis, that is postoperative respiratory failure. And type 4 is due to cardiogenic shock, and that will result in hypoperfusion of the respiratory muscles. So this finishes the quick revision of the respiratory failure. So the next important topic for the revision is the pneumonia. How do we classify this pneumonia is, like we classify the pneumonia, right, based on the anatomical division of or anatomical structure of the lung which is being affected. So we classify that into the airspace pneumonia and as well as the interstitial pneumonia, which is also called as the atypical pneumonia. The airspace pneumonia, again we classify this into the lobar pneumonia and then the bronchopneumonia, right? And as the word itself tells you, in case of lobar pneumonia, it is the entire lobe of the lung which is like affected. So here you will have lobar consolidation. And what is the most common organism that will be causing the lobar pneumonia is the strep pneumonia, right? And the next important organism is the Klebsiella. So the Klebsiella causing pneumonia, this is also called as the Friedlander's pneumonia, right? This is also called as the Friedlander's pneumonia. And in case of lobar pneumonia, the chest x-ray, it will show you the presence of lobar consolidation, and there will be presence of the air bronchograms in case of the lobar pneumonia, right? And in case of bronchopneumonia, if you observe, the bronchopneumonia, it is the bronchus which is affected, and you have the presence of the patchy consolidation. It is not the lobe of the lung which is affected, and it is a patchy consolidation what you will observe in case of the bronchopneumonia. And in case of bronchopneumonia, the organism that will be causing bronchopneumonia will be the Staphylococcus aureus. That is what is the organism causing bronchopneumonia. Whereas in interstitial pneumonia, this is also called as the atypical pneumonia because the typical signs of consolidation is absent, right? The typical signs of consolidation will be absent. So in case of atypical pneumonia, which is also called interstitial pneumonia, the organisms causing pneumonia will be like we have MLC, that is Mycoplasma, Legionella, and as well as Chlamydia. These are the important bacteria that will be causing the interstitial pneumonia. And apart from this particular bacteria, we also have certain viruses. These viruses that will be causing the atypical pneumonia will be the COVID-19 virus, right? And then the adenovirus, then the Epstein-Barr virus, and then the influenza virus. So these are the viruses that will be causing the atypical or the interstitial pneumonia. Now you take this word consolidation. What are the features of the consolidation? The features of consolidation is that these patients on inspection, the chest expansion on the affected side, right, the chest expansion on the affected side, it will be reduced. Whereas trachea, if you observe, it is like normal, it is present, it's centrally, right? Trachea is present centrally. Then what will happen to the vocal phragmitis? The vocal phragmitis, it is increased, right? Then percussion, if you take, it will be woody dull note, right? And the auscultation, you will have the tubular type of the bronchial breath sounds, which are high pitched sounds, and the vocal resonance, it is increased, right? And there will be presence of the egophony and as well as the bronchophony. So these are all the features of consolidation. These features of consolidation are absent in case of interstitial pneumonia. That is the reason why it is called as the atypical pneumonia. And particularly you take in case of lobar pneumonia, that is strep pneumonia, and as well as the Klebsiella pneumonia, you need to be aware of like which part of the lung is affected. You take in case of the strep pneumonia, the lobe which is affected is the lower lobe of the lung is affected, whereas in Klebsiella pneumonia, it is the posterior segment of the right upper lobe which is commonly affected. And this we call it as the bulging fissure sign in case of the Klebsiella pneumonia. And Klebsiella is like more severe than compared to that of strep pneumonia. In Klebsiella pneumonia, there is lung abscess very frequently being formed. There is development of pleural effusion, and there is also cavitation in case of Klebsiella. But whereas in strep pneumonia, the abscess formation is rare, pleural effusion is rare, cavitation is being rare. Okay, so that is what you will observe in case of the Streptococcus pneumonia, right? Then coming to the clinical features that you will observe, the clinical features in case of pneumonia is that they'll have the presence of cough with expectoration. So this expectoration, depending upon the color of the expectoration, we will be able to make out what exactly is the underlying organism. So if it is like green color expectoration, it indicates the bacterial infection, right? And that green color is mainly because of the presence of the enzyme that is myeloperoxidase, right? And if suppose if it is like rusty sputum, then you need to suspect the pneumococcal pneumonia as the organism causing the pneumonia. Then if it is like red currant jelly, you need to suspect the Klebsiella pneumonia. And if it is the presence of the blood stained sputum, then you need to suspect the tuberculosis. And if it is anchovy sauce sputum, then you need to suspect ruptured amoebic liver abscess. That is what is like, depending upon the color of the sputum, you will be able to make out the organism. And if it is like pink frothy sputum, you need to suspect the pulmonary edema, right? You need to suspect pulmonary edema. So this is about like making out the organism depending upon the color of the sputum. And the other clinical features will be like high grade fever will be there, dyspnea will be there, there will be also arthralgia and as well as myalgia, and as well as the presence of the headache, right? So this will be in case of your lobar pneumonia and as well as in case of bronchopneumonia. Whereas you take in case of the interstitial pneumonia, in case of the interstitial pneumonia, the cough will be dry cough. You don't have the sputum, right? And there are no signs of the consolidation, right? There are no signs of consolidation in case of interstitial pneumonia or the atypical pneumonia, right? And you take the organisms also. Legionella, this will be causing extrapulmonary manifestations in the form of diarrhea, right? And there will be also hyponatremia, and because of hyponatremia, these patients will be in a state of confusion, right? That is about Legionella. And what exactly is the drug of choice for Legionella? It is the azithromycin. And you take this mycoplasma, it is the smallest living organism, and the mycoplasma causing atypical pneumonia, what is the drug of choice? It is the same, that is azithromycin or erythromycin we give for the treatment of the mycoplasma pneumonia. Whereas you take the chlamydia, so we have a species called the Chlamydia psittaci, right? This we call it as the bird handler's pneumonia, which is very common in individuals who are having an occupation where there is exposure to the birds. And the treatment for the Chlamydia psittaci, the drug of choice will be the azithromycin, and the other drugs that we give is the doxycycline. So that is for the Chlamydia psittaci, right? So that is about your atypical pneumonias. Then how is that you will be able to assess the severity of the pneumonia? You will be able to, okay, before going to the assessment of the severity of the pneumonia, we have an organism called Pneumocystis jirovecii pneumonia, which is very common in immunocompromised states, that is the HIV AIDS and transplant patients. In them, the Pneumocystis jirovecii pneumonia is very common. And even this Pneumocystis jirovecii pneumonia, there will be interstitial pneumonia. The clinical features will be dry cough, and there will be exertional dyspnea. That is what you will observe in case of Pneumocystis jirovecii pneumonia, right? And how is that you will be able to diagnose this Pneumocystis jirovecii pneumonia? That is, the diagnosis is by fiber optic bronchoscopy, right? You need to do fiber optic bronchoscopy with bronchoalveolar lavage, right? Fiber optic bronchoscopy with bronchoalveolar lavage. That is the investigation of choice in picking up this particular organism, that is Pneumocystis jirovecii pneumonia. And the treatment for Pneumocystis jirovecii pneumonia, the drug of choice will be trimethoprim sulfamethoxazole, right? Trimethoprim sulfamethoxazole. That is the drug of choice in case of the Pneumocystis jirovecii pneumonia. Then how is that you will be able to assess the severity of the pneumonia? That is by a scoring system called as the 𝐒𝐫65. What is this 𝐒𝐫65? C stands for the confusion, U stands for the urea levels. If it is increased more than 7 millimoles per liter, then R stands for respiratory rate more than 30 per minute, B stands for blood pressure less than 90/60, 65 stands for age of the individual more than 65, and each parameter is given 1 point, right? And if the score is like, so each parameter, if it is present, 1 points are given. If the score is like 0 to 1, then you need to consider this particular patient is having the mild form of the pneumonia, and patients with score 0 to 1, they need to be treated on OPD basis, and you need to give the antibiotics, right? And if suppose if the score is 2, then in such case you need to admit the patient, that is IPD treatment, that is inpatient department, and you need to give the IV antibiotics. Then if the score is like more than 3, then these patients have to be admitted in ICU and they require the high-end antibiotics, right? Then how is that you will diagnose this pneumonia? One is by chest x-ray. Okay, chest x-ray in case of lobar pneumonia, I said you it is the entire lobe of the lung which is being consolidated, and you have the presence of air bronchograms in lobar pneumonia. Whereas in case of bronchopneumonia, you will have the patchy consolidation. Whereas in case of the atypical pneumonia, you will have what is called the interstitial pattern, or you have that lacy pattern on the chest x-ray. And the other way by which you can diagnose is the sputum culture and sensitivity. You will be able to make out, or you will be able to pick up the organism. So this is how you will be able to diagnose the pneumonia. Then coming to the treatment, like I said you already, like if it is like 0 to 1 OPD treatment, that is azithromycin or the beta-lactam group of antibiotics should be given. Whereas IPD treatment is that these are considered to be moderately sick patients, so they have to be given IV antibiotics like ceftriaxone, right? Or you need to give the fluoroquinolones alone, right? Or you need to give the amoxicillin, the clavulanic acid should be given, that is augmentin. So this will be the IPD treatment. Whereas when you admit the patient in ICU, they are considered as severely sick patients. These patients, they require the high-end antibiotics. So the organisms might be MRSA. So in methicillin resistant Staphylococcus aureus, you need to give vancomycin, and if it is vancomycin resistant Staphylococcus aureus, you need to give linezolid, right? And in case of the ICU admitted patients, the other antibiotics is piperacillin tazobactam should be given, or meropenem are being given. So high-end antibiotics and even the quinolones, that is levofloxacin, is also given in case of the patients who are admitted in ICU. So this is about the treatment of the pneumonia, and this is a quick revision of the entire topic of pneumonia. So the next important topic for the quick revision is the pleural effusion. So what is the normal quantity of the fluid in the pleural space? So that is around 5 to 15 ml. It is present in the pleural space, that is between the parietal pleura and as well as the visceral pleura. So this particular fluid of 5 to 15 ml will reduce the friction between the parietal and visceral pleura, and it acts as a shock absorber from external injuries over the chest, right? And what is the first line investigation for the diagnosis of the pleural effusion? It is the chest x-ray. But what exactly is the investigation of choice for the diagnosis of the pleural effusion is, it is the CT of the chest. That is the investigation of choice which can detect even the minimal amount of the fluid in the pleural space, right? Whereas the clinical detection of the pleural effusion, it requires almost 300 ml of the fluid that need to be accumulated within the pleural space. Now, if you take the pleural effusion depending upon the protein content, we classify the pleural effusion into two types, that is the transudative and as well as the exudative type of the pleural effusion. So transudative type of pleural effusion, it is mainly because of increase in hydrostatic pressure or decrease in the oncotic pressure. And usually it is the systemic pathologies that will be causing the transudative type of pleural effusion. Whereas exudative type of pleural effusion, that is due to increased capillary permeability, and it is the inflammation of the pleura, right? And it is the inflammation due to inflammatory pathology, and it is usually the local pathology that you will have in exudative type of pleural effusion. And the appearance is that in transudative it is completely clear, whereas in exudative you have the cloudy, right? The appearance will be cloudy. And if you take the specific gravity in transudative, it is less than 1.012, whereas in exudative it is more than 1.020 is the specific gravity. And you take the protein content, it is less than 3 grams per deciliter, whereas in exudative the protein content will be more than 3 grams per deciliter. Whereas if you take the fluid protein to the serum protein ratio, the fluid protein to serum protein ratio, it will be less than 0.5 in transudative, whereas in exudative it is more than 0.5, right? And you take the fluid LDH to that of the serum LDH, right? In the transudative it is less than 0.6, whereas in exudative it is more than 0.6. And the last three parameters in exudative, it comes under what is called as the Light's criteria, right? And out of these three, one should be positive to consider the Light's criteria to be positive, and that we consider it as the exudative type of pleural effusion. And very important is when you take out the fluid through the pleurisynthesis and when you keep it bedside, the fluid, it is transparent like water and it will never clot, right? It will never clot in case of the transudative, but the fluid, it clots, right? The fluid, it clots in case of the exudative variety. Then what is the most common cause for the transudative type of pleural effusion? It is the congestive heart failure. The most common cause for exudative type of pleural effusion will be pneumonia, right? Will be pneumonia, right? And the next important cause will be the tuberculosis. And what are the other causes for the transudative? The other causes for transudative, apart from congestive heart failure, it includes the chronic renal failure, it includes the nephrotic syndrome, it includes the hypoalbuminemia, it includes the malabsorption syndrome, it includes the hypothyroidism. So these are all the causes for transudative type of pleural effusion. Whereas exudative, apart from pneumonia and tuberculosis, we also have some drugs. These drugs include nitrofurantoin, then these drugs include bromocriptine, these drugs include dantrolene sodium, and these drugs include the amiodarone. So these are all the drugs which will be causing the exudative type of the pleural effusion, right? And apart from this, we also have malignancies, that is bronchogenic carcinoma, that will be causing the exudative type of pleural effusion, systemic lupus erythematosus, and as well as the rheumatoid arthritis. These are all the etiologies that will be causing the exudative type of the pleural effusion. And we have some terminologies called as the parapneumonic effusion or the 𝐮𝐵𝐝neumonic effusion. 𝐮𝐵𝐝neumonic effusion is that along with pneumonia, if there is presence of the pleural effusion, we call it as the 𝐮𝐵𝐝neumonic effusion. Then what will be the clinical features that you will have in patients with the pleural effusion? The clinical features that you will have is these patients, they will have dyspnea, that is exertional dyspnea will be there. Along with that, there will be cough with expectoration. So cough with expectoration will be there only if it is pneumonia or tuberculosis or bronchogenic carcinoma causing the pleural effusion. Otherwise, the important clinical feature will be the dyspnea. And on examination, you will find that the trachea, it is deviated to the opposite side. And what will happen to the chest wall movements? That will be reduced. And what will happen to the vocal fremitus? That is also reduced. And another important point is the percussion. So percussion, you will have the stony dull note, and what will happen to the breath sounds? The breath sounds will be reduced, and what will happen to the vocal resonance? That is also being reduced. So these will be the features that you will have in patients with the pleural effusion. So what exactly is the first line investigation in patients with the pleural effusion? That is the chest x-ray. What the chest x-ray will show you? The chest x-ray, it will show you that there is blunting of the costophrenic angle. Right, the chest x-ray will show you that there is blunting of the costophrenic angle. That is the earliest sign within the chest x-ray. And you have the presence of the homogeneous opacity, and the trachea, it is being shifted to the opposite side, and you have the presence of the LS S-shaped curve. That is what you will observe in case of the pleural effusion. Whereas the chest x-ray in case of hydropneumothorax, hydropneumothorax is that where you have the presence of the fluid and as well as air. So in case of the hydropneumothorax, you have, right, it is the one which will show you the horizontal level, right? You will have the presence of the horizontal level. That is what you will observe in case of the hydropneumothorax, right? And in case of the hydropneumothorax, on auscultation, right, what is that you will listen? So on auscultation, you will listen the succussion splash. That is what you observe in case of the hydropneumothorax, right? Now coming to the diagnosing the etiology. For diagnosis of the etiology, you need to do a pleurisynthesis. When you do a pleurisynthesis, you will be able to make out what is the underlying cause for the development of the pleural effusion. And pleurisynthesis, what is the intercostal space in which you will be doing this pleurisynthesis? See, this pleurisynthesis, it is useful for both. It is for diagnostic purposes and as well as the therapeutic purposes as well. For the diagnostic purposes or therapeutic purposes, the pleurisynthesis, it is being done in the 7th intercostal space, right? It is being done in the 7th intercostal space in the scapular line. That is the place, that is a preferred site for the thoracosynthesis, right? And some sources, it will also tell you that in 8th intercostal space you need to do pleurisynthesis, but the best would be decided by the ultrasonography report, right? Then, so this is about your diagnosis, and treatment is that you need to treat whatever is the underlying cause, you need to treat that. Then therapeutic pleurisynthesis, it is being done by inserting the needle in the 7th or 8th intercostal space scapular line. And when you are inserting the needle, please remember you have to insert the needle in the 7th intercostal space or 8th intercostal space over the upper border of the lower rib, right? And you should not pierce it over the lower border of the upper rib in the intercostal space, because you may injure the neurovascular bundle. And maximum amount of the fluid that can be removed is up to 1500 ml. If you try to remove more than 1500 ml, that will result in re-expansion pulmonary edema. That will result in re-expansion pulmonary edema. Now, what is the indication for the placement of the intercostal drain, right? Now, if there is like loculated pleural effusion, you need to place the intercostal drain and you need to inject the thrombolytic agents. And if there is empyema or if there is like hemothorax, that is the point when you need to place the ICD and you need to take out the fluid. So this is about the quick revision on the topic of the pleural effusion. So the next important topic for the quick revision is the pneumothorax. What exactly is the hallmark of the pneumothorax is the collapse of the lung. So why is it there is collapse of the lung in patients with the pneumothorax? That is because of increase in the positive pressure, right? That is because of increase in the positive pressure in the pleural space that will cause the collapse of the lung. And that is a hallmark in patients with the pneumothorax. And what exactly is the reason why the lung will expand? It is mainly because of the negative pressure within the pleural space during inspiration. That is what is responsible for the expansion of the lung, right? But in patients with the pneumothorax, there is excessive accumulation of air within the pleural space, and that will create a positive pressure. The positive pressure is the one which will cause the collapse of the lung. Then what are all the various etiologies that will be causing pneumothorax is, we classify the etiologies of the pneumothorax into the following. One, we have what is called traumatic pneumothorax, and the other one is the spontaneous pneumothorax. Now, what are the causes for the traumatic pneumothorax? The causes for traumatic pneumothorax, that includes like pleurisynthesis. The causes for traumatic pneumothorax is during mechanical ventilation causing barotrauma, that will be responsible for the development of the traumatic pneumothorax, right? And spontaneous pneumothorax, we classify that into primary spontaneous pneumothorax and secondary spontaneous pneumothorax. Primary spontaneous pneumothorax is that which is observed in individuals where there is no underlying lung pathology, and primary spontaneous pneumothorax is observed in those patients who are like mainly tall, thin, male smokers. Okay, so usually in case of the Marfan's or Ehlers-Danlos syndrome, these are the conditions where you have the primary spontaneous pneumothorax, right? Whereas you take secondary spontaneous pneumothorax. Secondary spontaneous pneumothorax is the condition where you have the presence of the underlying lung pathology. What are all the various lung pathologies that can cause the secondary pneumothorax is, in case of the lung abscess, in cases of the bacterial pneumonia, right? And in patients with the COPD, in patients with the cystic fibrosis, then in patients who have the endometriosis, that is pulmonary endometriosis, and those individuals who have fractured ribs. Okay, so these are all the causes for secondary pneumothorax. And you need to remember one important terminology called catamenial lung disorders or catamenial pneumothorax. Catamenial pneumothorax is that which is observed in patients with the in females with the pulmonary endometriosis, right? In these patients with catamenial pneumothorax, they will develop pneumothorax with every menstrual cycle, right? With every menstrual cycle, there will be development of pneumothorax. That is what is called as the catamenial pneumothorax, right? Now, tension pneumothorax is a very important form of pneumothorax. It's a medical emergency. These patients, they require immediate treatment. Tension pneumothorax is that where there is a rupture of the pleura, and the ruptured pleura will be acting as a flap valve mechanism. During inspiration, the flap opens and the volume of the air within the pleural space increases, right? And during the expiration, the flap closes, the air does not escape out. So with every respiratory cycle, the air, it keeps on increases, and that will cause collapse of the lung. And these patients with tension pneumothorax, which is a medical emergency, they require, right, they require wide bore needle insertion, right? And this wide bore needle insertion, it is done in the second intercostal space, mid-clavicular line, right? Wide bore needle insertion in the second intercostal space in the mid-clavicular line. So that is what is your tension pneumothorax treatment, right? Then what will be the clinical presentation? Dyspnea. So it will be sudden onset dyspnea, and on examination you will observe that the trachea, it is being shifted to the opposite side. That is one of the very, very important point. And next important thing is the chest wall movements, they are like completely reduced or absent because the lung is collapsed. And you take the percussion note. The percussion note, you will have the hyper resonant note, and auscultation, the breath sounds, they are completely absent, right? Breath sounds are completely absent. So this is what you will observe on examination. Then how will you diagnose this? That is by chest x-ray. So chest x-ray will show you that the lung is completely collapsed. You will have the hyperlucent lung fields, right? You will have the hyperlucent lung fields because the lung is collapsed, and there is absence of the bronchovascular markings. That is what you will observe in the chest x-ray, and chest x-ray is the first line investigation. And then how is that you will treat these patients? So in emergency cases, we do wide bore needle insertion, right? This wide bore needle insertion, it is done in the second intercostal space, the mid-clavicular line, right? And the other important part of the treatment, now if it is not an emergency, then you need to place, and with the wide bore needle insertion, if the dyspnea is not reducing, if the lung volume is not completely expanded, then you need to place the ICD. The ICD is placed in the fifth intercostal space, and the ICD has to be pushed up to the level of the apex. So that is what is the placement of the ICD. And this ICD, it is connected to the underwater seal in order to ensure that the air is completely aspirated out from the pleural space, and that is what is the treatment for the pneumothorax, right? And you need to know there are certain conditions where there can be recurrent pneumothorax. In patients with recurrent pneumothorax, you need to do a pleurodesis, right? What are the conditions where there will be recurrent pneumothorax? In patients with COPD where there is emphysematous bulla, they can cause recurrent pneumothorax. Catamenial pneumothorax, there is a recurrent pneumothorax. PCP pneumonia, that can cause recurrent pneumothorax. You need to do pleurodesis where there is obliteration of the entire pleura. The obliteration of the entire pleura can be done with the help of the povidone iodine. The obliteration of the entire pleura can be done with the help of the bleomycin. So this is about the quick revision of the very important topic pneumothorax, and this completes the quick revision of the entire respiratory system. Thank you very much.